Good morning, everyone. My name is Anis. Today, I will present about stroke thrombolysis. Okay, first we come to the introduction. Acute ischemic stroke continues to be a major cause of morbidity and is currently the third leading cause of mortality in Malaysia. So, ischemic stroke is the most common stroke, and hypertension is the most common risk factor, followed by diabetes mellitus. So there are three main causes of ischemic stroke, including atherothrombosis of large vessels, intracranial small vessel disease, and embolism, which may contribute up to 80% of the cases. And with the current advancement, timely intervention and early reperfusion, either via medical thrombolysis or endovascular treatment, the outcome of stroke has improved significantly. So what is the definition? What is stroke? Stroke is clinical syndrome characterized by rapidly developing clinical symptoms and or focal and at times global loss of cerebral function with symptoms lasting more than 24 hours or leading to death with no apparent cause other than that of a vascular origin. So, in cerebral infarcts, there is a restoration of perfusion to the ischemic brain tissues is important. So, there is a concept of existence of an ischemic penumbra to the current approach in the treatment of ischemic stroke. So, today the topic is intravenous thrombolysis and it is time critical treatment, and we should start the intravenous thrombolysis within 4.5 hours of presentation. So what are which patients do we start the IVT? So patient come with clinical diagnosis of acute stroke at presentation or acute disabling stroke within 4.5 hours of presentation, or present with wake-up stroke or stroke of unknown onset and are not eligible for endovascular thrombectomy. And when CT brain shows no hemorrhage or established large infarct core. So then we come to the contraindications for intravenous thrombolysis. These are the list for the absolute contraindications. First, if the pre-treatment SBP more than 185 or diastolic blood pressure more than 110, and second, if blood glucose less than 2.7, and if there is recent use of low molecular weight heparin within 24 hours or unfractionated heparin in the previous 24 hours and prolonged APTT, and if there is thrombocytopenia less than 100 or deranged coagulation profile. And for patients on the dabigatran, we can reverse its anticoagulant effect with idarucizumab. These are the list of the relative contraindication for intravenous thrombolysis. If the patient had serious head injury in the previous 3 months and recent stroke within 3 months, recent myocardial infarction within 8 weeks, GIT or urinary bleeding within the preceding 21 days, major surgery within the preceding 14 days, arterial puncture at non-compressible site within the last 7 days, prior intracranial hemorrhage of irremediable cause, seizure at the onset of stroke, premorbid modified Rankin scale more than 4, peritoneal dialysis or hemodialysis, and pregnancy up to 10 days postpartum, or nursing mother with no bleeding tendency. So if the patient came to us and with BP more than 185 and over 110, and if the BP is persistently high, we can give the patient IV labetalol 5 to 10 mg bolus, followed by continuous IV infusion to 8 mg per minute. And we also can give IV nicardipine 5 mg per hour. We can titrate up to the desired effect by 2.5 mg per hour every 5 to 15 minutes, maximum 15 milligram per hour. We also can give IV nitroprusside in ICU setting, dose 0.5 microgram per kg per minimum infusion, maximum of 8 microgram per kg per minute. And if BP not maintained less than 185 over 110, we cannot administer at the place. So there are two main drugs we can give for intravenous thrombolysis. First is IV infusion of altiplase 0.9 mg per kg, maximum 90 mg. 10% given as bolus over 1 minute and remaining dose infused over 1 hour. And the second drugs, IV tenecteplase 0.25 mg per kg, maximum 25 mg. We can give if the IV altiplase are not available. So these are the two drugs. Both drugs are thrombolytic agent. Altiplase, it is recombinant human tissue plasminogen activator and it produces local fibrinolysis by converting plasminogen to plasmin, and plasmin degrades fibrin and fibrinogen. For the tenecteplase, it is genetically engineered variant of altiplase with multiple point mutations of TPA molecule, and it has longer plasma half-life, enhanced fibrin specificity, and increased resistance to inactivation by plasminogen activator inhibitor 1 compared to the altiplase.
So Kak Hesah, stroke protokol pakai yang mana satu?
Altiplase.
Okay. Kita pakai satu lah, walaupun ada dua option. Tapi Kak Hesah, orang pakai satu je lah. Dalam dia punya kit lah.
Okay. Then during the administration of altiplase, we must do neurological assessment, GCS assessment and BP every 15 minutes during infusion of altiplase and 1 hour post-IVT, every 30 minutes for the next 4 hours, then every hour until 24 hours lapse from the onset of treatment. So if the patient develops sudden onset of severe headache, acute hypertension, nausea or vomiting, or worsening neurological symptoms with an increase in NIHSS by 4 or reduction of GCS by 2, we have to discontinue the infusion and do CT brain to look for any intracranial hemorrhage. And we have to avoid antiplatelet and anticoagulant drugs for the first 24 hours after administration of altiplase. So when we administer altiplase, there may be some complications happen, such as bleeding. If bleeding happens, we have to stop the altiplase infusion, and we have to do urgent CT brain if there is neurological deterioration. We repeat all the baseline FVC, RP, coagulation profile. Then we can transfuse IV cryoprecipitate and IV platelet. For severe life-threatening bleeding, we have to consider the IV tranexamic acid 1 gram over 15 minutes, can repeat every 8 hours, or recombinant factor 7A, a single bolus over 1 to 2 minutes. Another complications of altiplase infusion, patient may develop hypersensitivity, and we have to stop the IV altiplase infusion. We have to maintain the airway, breathing and circulation, and we can give IV diphenhydramine 50 mg, IV ranitidine 50 mg. If no improvement, we have to give IV methylprednisolone 100 mg, and if there is still no improvement, we have to give acute epinephrine 0.1%, 0.3 ml, or NAP epinephrine 0.5 ml. That's all from me.
Okay. Ni rujuk kepada yang CPG ya. Ada rujuk yang Hesah punya tak? Spesifik Hesah punya.
Saya tanya untuk drugs apa selalu bagi.
Tak. Ada tengok Hesah punya local punya protokol tak?
Tak.
Okay, tak apa. Just go back to the slide sebelum ni. Okay, lagi. Okay. Yang depan. Yang absolute dengan relative contraindication tu should be the same lah. Okay. So this is important because I think from this week or next week kita akan restart balik the acute stroke thrombolysis punya program lah dekat Hesah. Sebelum ni it was stopped because of COVID dan sebagainya. So I think beginning of this week or next week akan start balik lah stroke thrombolysis punya activation. Okay. So this is important because this involves you guys lah. Sebab benda ni korang kena tengok patient dan korang need to be aware of the activation macam mana, because macam yang Anis cakap tadi, stroke thrombolysis ni macam MI lah. very time sensitive. Cuma it's more complicated because kena CT scan dulu kan. Wajib CT scan dulu before decide nak thrombolysis or not. Tapi the process starts from when you recognize that the patient potentially have a stroke. Okay. Mungkin Dr. Villa atau Dr. Hafiza akan interject lah. Sama-sama saya cakap. So the most important part from our side is to identify that this patient is suitable or not for acute stroke thrombolysis activation. Okay, so patient datang, sometimes our MA pun dah very well versed lah, so they're not aware of this stroke thrombolysis. So sometimes before they brought in the patient, dia dah cakap, doktor, dia telefon yellow zone lah, kalau sekarang yellow zone lah. Doktor, we've got a patient suspect stroke. So in your mind, you should start be thinking about stroke thrombolysis lah. You need to start thinking about assessing this patient for stroke thrombolysis. Bila patient sampai, tak perlu ambil history dan examine macam biasa. You want to do history and examination yang ringkas to rule out certain things. Ada mention kan dalam slide sebelum ni, slide yang nak check DXT lah, nak check apa semua tu ha. So there are few things that you need to assess the patient. First, assess whether patient macam stroke or not lah. Usually it's very clear cut lah, patient present dengan left hemiparesis ke, dysphasia ke, facial asymmetry ke, or worst come to worst, the screening tu fast kan. Facial asymmetry, arm drift, slurred speech dengan apa?
Dengan fast lah.
So fast lah dia punya assessment, quick assessment whether patient tu ada stroke or not. And at the same time, you want to rule out benda-benda yang boleh rule out quickly, macam hypoglycemia, stroke mimic kan. So check lah DXT, it takes tak sampai seminit pun. It'll be very embarrassing, activate stroke protocol, hantar CT, balik CT, then found out patient actually hypo. So rule out hypoglycemia or anything else that you can rule out lah. Once you then lagi establish time, you want to make sure this patient ni betul-betul within the masa yang sesuai. Biasa kita ambil dalam 4 dan 4.5 hours lah. So kalau patient tu symptom start within 4 hours, eligible. Tapi kena clarify juga, adakah ini wake up stroke? Okay, wake up stroke ni maksudnya kena establish patient ni bangun tidur dengan symptoms ke, and masa dia tidur tu dia okey ke tak, pukul berapa dia tidur. Because bila wake up stroke ni, kita won't know lah dia ni 4 jam ke 5 jam ke, because this would be eligible for ni lah stroke activation. Wake up stroke rule out. Nah, so benda-benda yang korang kena tanya. Maksud korang kena tanya specifically, adakah patient ni bangun tidur terus ada symptoms? Bagi bangun tidur terus ada symptom, maksudnya it's wake up stroke. Okay. So then bila dah identify this patient is eligible, yelah of course you bagi tahu MO, your MO bagi tahu specialist dan sebagainya. To activate medical team, then you need to activate CT. Okay, so that because biasanya dia cakap you got a patient stroke for acute stroke thrombolysis, and biasa CT akan bagi priority for your patient, and make sure your PK, staff nurse semua ready to push the patient, sebab CT needs to be done within half an hour of patient arrival. Then the rest yang lain-lain tu hopefully medical team dah sampai and they will decide lah whether patient thrombolysis. Kalau kat HSAH, the thrombolysis will be done dekat critical bay, and then the patient will masuk CCU lah after thrombolysis. Okay, and it's the responsibility of the medical MO to ensure ada beds dekat CCU. So I think hari tu saya ada tanya kan dalam grup Housemen siapa yang nak jadi pelakon tu kan. Tahu tak kan, saya siapa nak jadi pelakon untuk yang medical nak buat video lah. Video tu kira dia nak tunjuk flow lah, how it's supposed to happen, start from kat radio dan bila masuk medical lah, so that nanti kepada generasi baru nanti boleh tengok video je lah, rather than nak, because the turnover of houseman MO is very high kan, so every batch ni buat kursus pun macam tak logik juga. Ustaz Okay? Okay ke? Faham ke? So, Dr. Fiza, Dr. Ati, Dr. Fiza, Dr. Ati, Dr. Fiza, Dr. Ati pula. Dr. Fiza, Dr. Vila ada nak tambah apa-apa ke? Faham Your role is to identify and activate shortcut.
Habis kan?
I think Dr. Fairuz dah cover good enough.
Dr. Fiza lah. Tapi kami
Okay, any questions pasal stroke thrombolysis?
Doktor, kalau activate stroke protocol nanti sari patient macam mana?
Okay, for the moment je patient tu sari ke, ada ILI ke, masuk red zone ke, kita exclude terus. Hanya untuk patient yang kat yellow zone dan tak ada ILI symptoms. So kalau dia macam ada stroke dan dia ada macam ILI, memang jatuh di timpa tangga lah.
Apa?
Jatuh di timpa tangga.
Absolute contraindication lah patient sari.
So
It's not an indication, just for the current scenario, our facility and the infrastructure not facilitate much for the sari. Tapi sebenarnya kat luar negara tu memang dia sari is tak kira pun sari tak sari, dia pun resist criteria tu masuk juga. Dia candidate. It's just for our current setting, we can do much. So we purely choose non-sari patient.
Mungkin lepas ni kita akan berubah lagi, tapi in the next few weeks ni untuk mula-mula nak restart ni yang patient kat yellow sahaja, yang tak ada ILI symptom, bukan sari. Lepas ni mungkin ada berubah, kita akan update lagi lah. Keep everything simple supaya semua orang tak pening, yang non-sari saja. Okay, so
sorry, tambah sikit. Saya tak sure Dr. Fairuz cakap ke belum lagi sebab baru join. Eligibility for intravenous thrombolysis ni selain daripada 4 point yang di present, actually not acute stroke yang kita thrombolyze, walaupun patient acute stroke, but if the NIHSS score is very low or very high, kita tak thrombolyze juga. Contohnya very minor stroke, NIHSS score less than 5 kan, itu tak thrombolyze. Ataupun NIHSS score more than 22 pun kita tak thrombolyze. Okay, ada maaf kalau tak sure Dr. Fairuz cakap ke belum, cuma saya baru join je.
Saya tak cakap, saya NIHSS saya tak ingat, too complicated. Tapi your role paling penting, identify and the activation involves inform medical MO on call dan juga inform CT room. Dalam plan thrombolysis, walaupun tak fully finalized, sebab sekarang kan CT kita macam pagi buat sehari COVID lah, petang baru buat yang normal or the other way around. Potentially, kalau kata CT room is occupied or CT room is doing patient sehari or COVID, they mungkin akan buat MRI adalah spesifik protokol dia. Tapi whether benda tu akan jadi reality or not, kita tengoklah macam mana. Okay? Yang penting activate dulu. And beware doktor, dan untuk houseman, darah yang untuk patient stroke ni kena run ke lab Lepas ambil kena hantar ke lab dengan segera. Kena ada runner hantar, tak boleh tunggu PPK hantar. Because it's gonna be given priority untuk proses. And Dr. Hafizah pun dah buat folder cantik-cantik untuk stroke protocol. Sebab dia ada specific forms dia supaya korang tidak tercari-cari. Be aware, folder tu ada kat mana, apa ada dalam folder tu. Kena aware lah benda tu sebab unfortunately itu kerja hakiki houseman lah. Mengisi borang. Doktor MO semua dah tak pandai menulis lah.
Sorry nak tambah sikit pasal kena bawa lari all the sample. Betul kena run ke lab tu, sampel apa yang kena hantar lab segera ialah ABC, RP dan coag. Especially the FBC and coag because coag it take times. Sementara nak tunggu result almost 1 hour the coag. Tapi make sure before you send, please inform lab, the hematology lab, that you want the FBC and the coag result urgent. Kata dia is a stroke activation. Nanti dia orang tahu apa satu. Bagi SP number, then you need to run to the lab untuk hantar the sample.
Tak payah cakap banyak-banyak Cakap kita ada sample stroke protocol activation. Sample apa-apalah. Dan lepas tu hantar. They aware, tak payah cerita banyak-banyak. So because this is a multidisciplinary, multi-department punya benda lah. So semua orang aware, just mention stroke protocol. Okay, so sebab good thing lah tajuk CME ni come up this time kan. Sebab dengan CFO-nya nak ada dekat ED, dengan stroke protokolnya nak start balik, so that you guys are aware. And satu lagi, stroke protocol HSAH office hour sahaja. Lepas office hour tidak berjalan. Janganlah activate stroke pukul 12 malam apa semua pun tidak berlaku lah. So be aware of the local punya, this is something yang local lah. So local punya protokol. So korang kena aware lah. Sebab biasalah houseman kan, kena aware lah benda-benda ni. Kalau tak, kami nak marah siapa lagi.
Okay, lab nak kena inform ialah lab hemato 3208. Dan satu lagi, tahu tak yang stroke ni kita yang first hospital kat Kedah. Yang tu je lah nak beritahu.
Ada apa-apa soalan tak? Apa-apa yang tak jelas? Janganlah nervous sangat. InsyaAllah saya tak marah lah. Dr. Hafizah saya tak tahu lah.
Tak kait tak marah.
Ada apa-apa soalan pasal MTP, pasal stroke protokol dan sebagainya. Sebab kalau ada benda tak clear, kita boleh clearkan sekarang.
Ada orang kata nanti kita ada CFO nak kalau dah minta CFO macam mana nak part of MTP ke tak? Hello? Sorry, MTP dah present lah, Feroz?
Dah.
Oh dah.
Akmal yang present. So Akmal, soalan Dr. Hafizah. Jangan kata ada sebelah, tak ada sebelah ni
kita
sebelah.
guna CFO, department kita nanti dah dapat CFO. Jadi bila kita dah guna CFO kita, adakah untuk MTP nanti kita nak request CFO lagi ke tak?
Tak payahlah sebab dah ada dekat kita.
Salah. Apa yang MTP dalam CFO kita tak termasuk MTP. Okay? So CFO untuk kita. MTP tu kena lain punya activation.
Tak kena mengenal lah Doktor.
Ya, betul.
Jangan salah faham Just because kita minta CFO doesn't mean kita activate MTP. In normal situation pun kadang-kadang kita minta CFO, minta saline dan sebagainya, kita tak activate MTP. MTP ni bila patient bleeding banyak and you don't think the normal time untuk normal turnover time untuk saline procurement mencukupi lah. Kita nak lagi cepat. Sebab the idea of MTP ni, it saves you from isi borang banyak kali. It's like a automatic system. Once you dah activate MTP, blood bank akan keep processing package 1, package 2, package 3, package 4, package 5, package 6 tanpa perlu order seterusnya. So
faham.
it's automate the process lah. Tapi just because activate dah ambil CMEho, activate MTP kena formal. Activate MTP, somebody must give EP lah biasanya. Kalau kat ED EP lah. Kalau surgeon yang activate, surgeon lah. Ada order spesifik activate MTP, and the PA system akan berbunyi lah, MTP activated dekat ED, MTP activated dekat ED. So it's something yang very formal, kena activate. Tapi just because ambil CMEho doesn't mean MTP is activated. Kena itu pun kena faham.
Faham.
Takut salah faham pula bila dah ambil CMEho kata MTP activated. And dalam documentation kena tulis MTP activated by whom, what time dan sebagainya.
Faham.
Okay.
Okay, thank.
Lagi apa, ada soalan lagi berkisar MTP, stroke protokol? So, saya pun faham korang mungkin tak biasalah, korang ni generasi Housemen PKP kan, mungkin kurang arif sikit lah dengan stroke protokol sebab yalah benda ni baru nak start balik kan. Tapi ada soalan ke? Tak apa, sama-sama kerja nanti pun boleh tanya. Okay Anis? Okay Akmal?
Okay, saya.
Okay. Umi Adiba, Liana Jusni, Bashir, Hafiz, Izzatul Alia, Izzah Faizul, nama dekat-dekat ni. Alia. Okay.
Okay, saya.
Okay. Saya tak ada lah. Dr. Vila, Dr. Fiza, Husna, ada nak cakap apa-apa ke? Ada pesanan story.
Kalau masa tugas pasal stroke dengan MTP tak clear, jangan segan bertanya. Dan satu lagi, buatlah segera.
Activate stroke ni hanya office hour sahaja ya, 8 hingga 5 sahaja.
Okay, thank.
Okay.
Dah, sekejap. Office hour 8 sampai 5, weekend ke tak ada?
Weekend tak ada.
Alright, okay.
Tapi katakanlah mai during office hour kan, patient datang pukul 7.50 pagi. Kita tunggulah pukul 8 kita activate.
1 dan 2 masih berjalan.
Tak ada.
Takutlah
Okay.
kita kata office hour ke, patient mai pukul 1, tak activate tak. Pukul 1 masih activate.
Okay, thank.
Bukan macam RTK kat luar tu kan. RTK kat luar tu pukul 1 ke 2 tak berjalan. Tapi kalau stroke protokol 1, 2 berjalan.
Okay, thank.
Okay. Tak apa, pelan-pelan lah. Ni at least nak, the aim of the topic at least to make sure you guys aware lah of benda-benda ni. Bukan find out pasal benda ni masa jadi cmeho ke, dia sebenarnya. Okay, tak ada apa-apa dah. Kalau saya boleh cakap thank you dah. Orang lain tak tahulah.
Ya, betul.